who will talk you through, and we'll stop and pause on the way to look at your questions and your discussion and answer the questions that you're going to ask us. So hopefully this will be informative. We're going to get underway because we've got a couple of hours, but we'll break it up as we go. Over to Helen.
Okay, thank you, Adele. Good morning, everybody. Hope you can hear me. Obviously, let us know if you can't. What we're hoping to cover today is, as it says on the screen, and again, I hope you can all see that, we're going to give you a very quick introduction to the concept of long-term conditions and also having multiple long-term conditions. We'll also talk a little bit about frailty and older people living with frailty and becoming more frail and how that feels. We're then going to move on to people who fall and the problems of falling in older people, and we'll finish up with a very quick overview of osteoporosis, which is a very common condition in older people and of course can lead to fractures, which can be very serious for many older frail people. So just moving on to the next slide. As you probably all know, we have an ageing population in the UK and of course across the whole of the developed world. In fact, the whole world now, the population is ageing. And what we know is that's very good news. It's good news for the population. It's good that we are living longer. But the issues that we have as a society are that on average now, death is preceded by about 10 years of chronic ill health, and the figure is rising. So we know now that men and women, average life expectancy is certainly well into the 80s, but from the age of 65, we know that most people will live another at least probably 20 years, but 10 of those years will not be in good health. It will be in poor health and in disability. So as a society, that's a real challenge for us in terms of how we support those older people living with frailty. And this graph that you have on your screen there is from the Lancet in 2012, so it's a couple of years old now, and it's based on the Scottish population, but it's very relevant to the whole of the UK. And what you can see really there is that having one or more long-term conditions is absolutely the norm now. There are very few people that just have one long-term condition existing on its own. So we know now that when people are 65, the majority of them have over two or more conditions, and the majority of over 75s have at least 3 conditions. And we also know that most people have 2 rather than 1. So the old model really of single disease states, being a nurse that specialises in chronic heart failure or specialises in COPD or diabetes, probably doesn't work as well as it used to. Most people have many conditions, and those conditions coexist. And as nurses, it's our challenge to support them in dealing with those multiple problems. So where does frailty fit in? Just a little question for you now. If you've met people that you consider to be frail in your clinical practice, just think about some characteristics that those patients might have in common. And maybe just type me a few words into your box there and let me know what you think. What does frailty mean to you? What are the characteristics of frailty? I'll just give you a few minutes maybe, or just a minute or so, just to type in a few words for me. Oh, screen's frozen. Amanda, hopefully your screen's freed. Yeah, we've got a few coming up there. We've got people over 65, so we're thinking predominantly older people. Poor mobility, underweight, yep, somebody's just said low BMI, thank you. Yes, absolutely. Any other indicators of frailty that you've come across? Okay, well, certainly you're absolutely right. Frailty is much more prevalent in older age. So over 65 is absolutely right, and becomes much more prevalent the older we get. So over 65, but much more prevalent in over 75s and again in over 85s. Dell's just fiddling around, so then I'll just change the screen so we can see some of these things as we go. Yeah, someone said high falls risk now and poor health and dependence. Yes, again, you're absolutely right. So people poorly mobile, not getting around as well as they did. Underweight is actually right. Weight loss is an indicator of frailty. We normally think about 5% weight loss over a period of about 6 months is an indicator of frailty. low BMI, you've said, dependence, yeah, needing more help with activities of daily living, and falls risk, yes, people who are frail often fall, yeah, absolutely right with all of those. What you're seeing on your screen now is a definition of frailty, and if you read the literature, there are many definitions out there, but I think this one really sums up well the issues of frailty and how it affects people in their day-to-day life. So frailty itself is not a disease, it's not a condition, but it's a combination of the natural ageing process, and then you superimpose on that a variety of medical problems that the long-term conditions cause. It really focuses on that loss of reserve, that loss of energy, that loss of well-being. And people often think about frailty as a functional decline, but actually it's not. It's much more about that loss of reserves, that loss of ability to bounce back. You've got a definition there from Rockwood, that's Ken Rockwood, who's a Canadian geriatrician. He says a multidimensional loss of reserves, energy, physical ability, cognition and health. And I'd urge you to have a look at Ken Rockwood's work. He did a lot of the early research into frailty and its impact on patients. You can see another graph on your screen now. This came from a review of frailty in the Lancet in 2013, and again, worth a look. This graph really sums up, I think, frailty, and again, that loss of physiological reserve. So going upwards there, you've got functional ability, and the dotted line is often is that line between independence and dependence. Now, someone said when we asked about characteristics of frailty, it's about being more dependent. Now, the red line there is a frail person going along, and actually they probably look relatively well. They look like they're coping quite well. They look like they're managing independently. But then something happens, and that might be something like a minor illness, like a urinary tract infection or a chest infection. It might be a change in their social circumstances, or it might be we just give them another tablet, because that in itself can be an issue for frail older people. And they very quickly then dip down below the dotted line into dependence and needing help with their activities of daily living. And if we don't intervene very quickly there, the patients will really struggle to get back above that independence line and return to their previous functional state. So think about frailty as that loss of physiological reserves, that loss of ability to bounce back when a minor stressor happens. And this is really just, again, to tell you a little bit around some of the research around frailty. This is an old study now by Freed in 1999, but still very relevant for today. And it probably describes frailty in a slightly different way, in that it's really thought of as a trajectory between sort of healthy ageing, moving on to chronic vulnerability. Perhaps people are starting to accumulate long-term conditions. An acute illness happens, you have an acute loss of capacity, and then there is a stage of recovery. How much recovery really depends on what we can do to support that person to regain their independence and their sense of well-being. These are the recognised indicators of frailty, and it's exactly as you've already said to me. These are recognised indicators that would make you think that perhaps frailty is starting to happen. So reduced mobility, muscle balance, lack of strength, poor balance, deficits in motor processing, cognitive decline, poor nutrition, weight loss we've already mentioned, that lack of endurance, reduced stamina, and a limitation on physical activity. And it's a bit of a downward spiral really, because if people feel they have less stamina, they're more tired, they're not getting around as well as they did, then they will start to limit their physical activity. Maybe they walk to the post office every day, now they can only walk to the end of the road or only get to their gate. But because they then limit their physical activity, they soon become deconditioned, their muscles become weaker, and frailty becomes that downward spiral. So it's around supporting people to regain some of those aspects. Just type into the box how long you think it takes frailty to develop. Just give me, again, just a few pointers. What do you think? How long does it take to become frail?
That's a good question. Yeah. I'm feeling frail today.
Yeah, I know we all feel frail some days. Okay, so we've got 2 years there from Rebecca, a couple of weeks from Lucy. Natalie, dependent on the person and their health. Yeah. Yeah. Any other thoughts on that? Weeks and months, yeah, yeah. Okay, yeah, we've got 6 months now, so we're getting a bit longer. Yes, the research is quite clear that frailty takes between 5 and 15 years to develop. And yet we're always surprised, aren't we, when people are suddenly admitted because they're falling or they have one of the frailty syndromes, they become less mobile, they suddenly become confused. The research shows that the clues to developing frailty were there often 5 or even 10 years ago. And it's something around that slowing down. You know, no patient's going to say to you, I'm becoming frail, nurse. But what they might say is, it's just taking me much longer to get dressed in the morning. I'm not able to get about as well as I did. I feel tired all the time. And those are real indicators of early frailty. And we have a really good window of opportunity to intervene there and support people to become more active and to regain some of that independence. So we've already talked about some of the frailty syndromes. These are the frailty syndromes which were put together by the British Geriatric Society a couple of years ago now. And I think, you know, a lot of things we've already talked about, but also things like urinary tract infection, having lots of urinary tract infections or suddenly becoming incontinent when a person was previously continent. Pressure sores, as you would expect. If people are less mobile, much more prone to pressure sores and problems with skin integrity. And I really like that the British Geriatric Society highlighted polypharmacy as an issue. So just taking more than 4 medications is a frailty syndrome in itself. And often, for those people, we're doing more harm than good with some of those medications. So we will cover a little bit about that later on in the session. And I also like the fact that the British Geriatric Society have recognised the importance of carers here and thinking about how it impacts on carers supporting an older person becoming more frail. So why worry? Does it matter if people become frail? Well, yes it does. The evidence is that frailty is a really reliable predictor of a general decline in health. And people who are becoming frail face a future of deteriorating mobility, disability, hospitalisation, but also a much increased risk of being admitted to a care home setting, and frailty is highly correlated with death. We also know that it's correlated with cardiovascular disease, low education and poverty. And it's worth just thinking around that because as clinicians we certainly haven't got all the answers to frailty. And there's an increasing body of evidence that the social factors of frailty are as important as the clinical indicators. So for example now we know that older people who are socially isolated are much more likely to become frail than those who have really good social interaction. And we know now that in older age that being socially isolated and being lonely is as bad for you and is as much of a risk factor as smoking 15 cigarettes a day in terms of developing frailty in later life. So we haven't got all the answers as clinicians. We need to work with communities and voluntary sectors to ensure that older people are connected with their communities and don't feel lonely and socially isolated. We also need to think about the social aspects, good housing, making sure that people have adequate incomes. All of those things are as important as anything that we can do clinically. And this is a very good study. I'd urge you to have a look at it. It's from Caroline Nicholson and her colleagues who has done a lot of work around the actual lived experience of being an older person with frailty. What does it feel like and what does it feel like for their carers? And you've just got a few quotes there from the study. And you know, you can see really how frailty impacts on people's quality of life, how people feel their life has shrunk. That's the way often people describe it to me. They're just not able to get out. They perhaps live in their house. They live in one room even because they're just not able to engage with society as they did. But also the impact of frailty on people's confidence. The quote there you've got at the bottom, I think that lady sums that up very well. And if you have less mobility, you're not able to do as much, you're falling more, you very quickly lose your confidence to get out and about and to be socially active. Just to bring this up to date, Age UK did a very good study last year, again talking to older people and their carers. If you go onto the Age UK website, you can have a look at that. and they also have 6 very good videos of people talking about how it feels to be frail. So I'd urge you to have a look at that if you've got the time. We're going to take a quick pause there, I think.
Right, has anybody got anything that they want to say about what Helen's been talking about, or have any questions for Helen? Were there any surprises for you in what she was saying, or is there anything, apart from the fact that I've messed up on just got a slight, oh here we go, slight technical hitch where I cut everybody off. Has anybody got anything that they want to raise at this moment? Just give you another minute or so, or any questions about what Helen's been saying? I find that what you said about the isolation can be as bad as many other things. I thought that was really interesting. I've seen some things on television where they've had getting young people to befriend a neighbour who's frail or isolated, perhaps an older person, and what a difference that's made to their life.
Definitely.
Okay, so Rebecca's got a question.
Okay, so clarifying the definition of frailty and long-term conditions. Can these conditions advance frailty? So you're doing an essay, Rebecca, that's focusing on a lady with cancer and her mobility, etc., has that advanced her frailty. Yes, there's definitely a link between having more than one long-term condition and increasing frailty, because the changes that happen to our body with long-term conditions will often contribute to the increasing frailty. So, for example, we know having cardiovascular disease or cerebrovascular disease will make you more prone to becoming frailty perhaps earlier than you would have done if you hadn't had that. But I think frailty is very multifactorial. There are lots of influences. So you will also find people, older people who've become frail and they don't have multiple long-term conditions. So again, there's things that we still don't understand. But I would say if you have a person who has cancer, poor mobility, then those are certainly risk factors to her becoming more frail. Any other questions at this stage? Anything there in the box, Adele?
No. Right, we'll move on now.
Okay.
Oops, I've moved on so fast I've jumped to 2 slides.
There we go. So this is a case study, and this is a patient of mine, actually when I was a community matron a few years ago. Hope you can all see this, but it just really demonstrates how some frailty syndromes become implicated in older people's decline. So this is Mr. Jones, and he was 85. He lived on his own in a house. He slept upstairs, but he had great difficulty in getting to bed. He had lots of osteoarthritis in his left hip, and he had a stroke, so he had a mild left-sided weakness. Now, his current problems when I first met him was he had high blood pressure, and his GP had quite correctly, aggressively treated his raised blood pressure. He wanted to try to reduce the risk of him having a further stroke, but unfortunately when we give people lots of hypertensives, antihypertensive medication, then often they have dizzy spells, particularly when they get out of bed in the mornings or when they stand up from the chair. So thanks to all of these tablets, he was now on 7 medications a day, so he was taking lots of medications. He has some osteoporosis. He suffered a fractured wrist the year before, and at that time he was noted to have osteoporosis, so a weakening of the bones. And then when I met him, he'd had a fall, so he got out of bed one night. He needed to go to the toilet urgently. He felt dizzy when he stood up, and then he fell over. He fell onto his left hip, causing extensive grazing and bruising. But the issue for poor Mr. Jones was he couldn't get up, and he lay on the floor overnight, which then led to him having a pneumonia and a sacral pressure sore. So just very quickly, just type in the box, what frailty syndromes do you think are implicated in Mr. Jones's decline? And any thoughts on any services that you think would be involved in his care to keep him independent at home? Just give you a little while to do that. Yeah, someone said a package of care. Absolutely. He certainly needs some additional support at home to keep him independent. Someone else has now said, I can't see your names now, I'm sorry, falls, mobility, needs pressure area care, and he has polypharmacy, so he certainly needs a review of his medication. Does he need to take all of those medications now, or are they actually doing more harm than good? You should have a lifeline. Yeah, definitely. So for those of you that don't know what a lifeline is, it's the pendant that goes around people's necks that they can wear all of the time, and if they fall, they can press a button to alert and call for help. Home care, yeah, Meals on Wheels, absolutely. All things aimed at keeping him safe. He certainly needs a full falls assessment, and we'll talk about that a bit later today. And yes, so really he doesn't have anything at the moment that's helping him to remain independent at home and to prevent these things happening again. He already has osteoporosis, he's already fractured his wrist. I would say he's a fractured neck of femur waiting to happen. And if he breaks his hip, he will really struggle to maintain his independence at home. So it's very much now about being as proactive and preventative as we can. And also, you know, working with Mr. Jones about what his goals are, what does he want to achieve, and how can we support him. So in terms of how we might find frail older people, we've said that frailty shouldn't be a surprise. It develops very slowly, often over many years. How can we find frail older people? Well, there are some very good objective tools that we can use. And I'm just going to talk about a few of those simple tools that you may want to apply in your practice. So the first one there is very simple. We've already talked about the indicators of frailty. So you can just talk to patients and assess them and see if they have any of those indicators. So 3 out of 5 of any of these indicate frailty. It's a very good, valid test, very, very highly predictive of frailty. Has anyone seen the clinical frailty scale? This is a tool that we use at the moment in Cornwall across acute community and primary care, and we're starting to use it in other sectors as well, including our voluntary sector. This is a very simple tool. It was developed in Canada by Ken Rockwood, who I've already mentioned to you. And what it does is so simple, it just enables you to talk to your patient, to assess your patient, and then to score them between 1 and 9. And it's a real trajectory, so 1 is very fit and 9 is terminally ill. And your patient can be anywhere along those scales, and as you can see, at each number you've got a little description of, oh, we seem to have lost the screen there, Adele. Oh, we're back, okay. No, we've gone again, Adele.
We're just going to stop for a second.
Sorry, we just lost the screen a moment. Adele's just getting it back.
Look, let me email you this. Oh. Well, we got 500 potential for 500.
Can we get the screen back on? Yeah, lovely. So we've got the I have it.
I'm having troubles too, but I can go back. Send them the link again.
We just need to go back one screen. We've gone on past that.
Yeah, or you can email them. I'm going to send you this thing here because I can't find them easily on the. I can't find their names on the email thing. We've got 22 people on.
Okay, so we're back to the clinical frailty scale here. So as I've said, it's just a case of talking to your patient, assessing your patient, and then you can easily score them.
Okay.
So another reason we like this tool is because it can certainly give you an idea of the scale of frailty. So how far on along the trajectory the patient is. So are they only mildly frail? Are they more severely frail, or are they at the end of their life? And that can really help you target the interventions that work. So if people are mildly frail, you'd want a very different intervention to those that are more severely frail or those that are at the end of their life. So this scale is used extensively in Cornwall now. May well start to see it being used in Devon and in other areas. And at the moment I'm on secondment to NHS England, and we're working nationally to get the scale adopted because it is very simple and something which we can all use. But also I work quite extensively with volunteers who support frail older people, and they use this tool as well. You don't have to be a clinician to use the tool. Nice and simple. In terms of preventing frailty, well, we know now that there are certainly some preventable or modifiable factors that contribute to frailty. And just go onto the NICE website when you've got time. There's some draft guidance there at the moment, and it is in draft, but it's still worth a look, which is around the prevention of frailty in midlife. So things that people can do in the midlife to prevent frailty in older age. So those are some very simple lifestyle changes that people can make. But what I've got here are things that we can do if we meet a frail person now, an older person living with frailty, how we can support them to stay as well as possible and maintain their independence. So firstly, we should optimise the treatment of their long-term conditions. It's important that we do that. But then there are some really simple things that we can think about, and we've just got it sort of highlighted there as frailty just to help you remember, really. But the important thing is to think about food intake and maintaining food intake. We've already said that weight loss and a low BMI are indicators of frailty, so we need to think about how older people can maintain their diet and whether they need support to do that. Exercise is one of the key modifiable components of frailty. If people undertake resistance exercises, things that strengthen their muscles, and also balance exercises, then you can reverse some of the early stages of frailty. Those are one of the most important things that we can support our patients to do. So while it's very easy when we start to feel a bit unsteady on our feet to maybe do less, it's at that point that we should be pacing ourselves but doing more. So trying to strengthen muscles and to improve balance. The A there, we've got atherosclerosis prevention, and that's really about healthy lifestyle. So maintaining a healthy weight, we've talked about making sure that blood pressure is within the accepted range, not smoking, reducing alcohol intake, all of those things, because they link to cardiovascular and cerebrovascular disease, are very important in the development of frailty. We've already talked about social isolation. Going out and interacting with the community is incredibly important. I've also got pain in there, and often what I find when I meet patients is their ability to go out and interact is limited by pain. And there's often a feeling that as we get older, we must expect some pain in our joints, pain in our back, those sorts of things. That's not the case. Often, we can control pain, and there are very safe ways of doing that. So always ask people about pain and are they in pain, and think about analgesia and effective ways to control that pain. Talked about balance exercises, and then in America, in the USA, they do a yearly check at the moment for testosterone deficiency in men, because low testosterone is highly linked to frailty. Now, we don't do that in the UK yet. I don't know if that will start to come in, but it's just to let you know that low testosterone is a risk factor for frailty. And then just moving on a little bit about, a little more in depth around some of the interventions that we can use to prevent and to treat frailty. We've talked about exercise, that has a really good evidence base. We've talked about nutritional interventions. There's not a huge amount of evidence out there yet to say that if we improve people's nutritional status, they will become less frail. But of course, it does make sense to try and intervene if people are actively losing weight at that point. I'd like to say there's a magic pill, and there's lots of research at the moment going into looking at, is there a pill to treat frailty like all other long-term conditions? At the moment there isn't, but the things that are being looked at are ACE inhibitors. The things at the moment that we use to treat heart failure and high blood pressure, we know that they can improve skeletal muscle function and structure. So there's something around the link between that, but we don't fully understand it yet. We also know that an increased vitamin D intake is important in preventing frailty, but that is controversial because you may well have seen in the press over the last couple of years, vitamin D and high levels of vitamin D intake have been linked to cardiovascular disease. So at the moment we don't know enough to recommend that. And I've already talked about testosterone. You'd think it would make sense to treat frail people with testosterone, but there are lots of adverse effects of testosterone. So again, we don't know enough about that. What we do know is that a comprehensive geriatric assessment delivered in the community has an increased likelihood of continuing to live at home. So comprehensive geriatric assessment, or CGA as we often term it, is the gold standard for older people living with frailty. Now on your screen now you've got a table of the different domains of a CGA, and if you have a look at it, I think it's what we do as nurses all the time. You know, we talk to patients, we assess them, and we think very holistically. We don't just look at their nursing needs, and you know, there may well be some additional nursing assessments you'd want to add to this. We don't just look at their mental health issues, their medical issues, their functional capacity, social environment. We tend as nurses to look at all of those things together. So I think we do a pretty good job as nurses carrying out a CGA. And if you're thinking about frail older people, and maybe you've carried out one of the case finding assessments that I've talked to you about, these are the sorts of things you should be thinking about. And as you can imagine, if you talk through these elements with your patients, what you'll be able to do then is to come together with your patient in partnership then to think about their goals and what they want to achieve, and then plan care effectively with them. So we know CGA is a very good tool to use with frail older people. And again, lots of evidence and research out there which you can have a look at if you're particularly interested. So just to summarise that part of the presentation around frailty, we know that there are recognised indicators of frailty that we can detect in clinical practice. I would argue we need to start detecting those much earlier because we have a window of opportunity where we can intervene very effectively. We know that there are screening tools that can be used, and I've talked to you about just a couple of them, but there are many more if you want to search for them. There are very simple interventions that can be used to slow deterioration in frail older people, and we know that we should use a comprehensive geriatric assessment framework to guide that holistic management of frail older people. So are there any questions at that point before we move on to the next part of the session? Just take a little more time. Yeah, it does. Probably one for you, Adele. Do they have to include any frailty assessment in our essays?
Let's just say if you did, it would look pretty impressive, but it is up to you. Or you can make reference to the need for frailty assessment. I wouldn't say that goes right across the board, although Helen's kind of indicated that somewhere in everybody's lives there's a potential for them to become frail. So I know you've got to write your assignment about long-term conditions and pick a case to explore, and you might now like to think that you might want to include frailty assessment within it, or make some reference to frailty assessments.
Just another quickie really, if you are thinking about frailty assessment, depending on where you're working, where your patient is at the moment, certain assessments work better than others. So certain assessments work better in acute settings, certain ones work better in a community setting. I would recommend you to go onto the British Geriatric Society website and have a look at Fit for Frailty. That's a very good document which they've just produced, and summarises a lot of the case finding tools that are out there. So if you wanted a little bit more information for your essay, have a look at those. There's also just been published a very good Effectiveness Matters. Hopefully you've all been able to have a look at Effectiveness Matters in the past. They're monthly evidence summaries that come out of the NHS Innovation with the University of York. They're published every month on a particular theme, and the one in January was on frailty. So that gives you a really good summary of all of the evidence, which again I think would work well for your essays and as good background reading.
Kim's just joined us. Well, she has been with us for a little while, and I wondered if she's typed in a point there. She's just trying to help some students who have had some problems logging in. I don't know what you want, if you want to add anything to our comments about including frailty assessment in their assignment, Kim. She's probably gone off now. Anyway, if she does, we will share it with you.
Okay.
Okay, we're going to move on now.
All right, we'll move on to the next part of our session, which is really just to talk a little bit about polypharmacy. I've mentioned polypharmacy as a frailty indicator and a real issue with older people who are living with frailty, and that how polypharmacy can actually contribute to frailty developing. And again, I just want to tell you about a patient of mine who's it's a few years ago now. But this is just one of the hazards really, I guess, of just adding in one more drug for very good reasons, but the impact of one more drug on a frail older person. So this is Dorothy. She was an 85-year-old woman who had osteoarthritis of her knees, so she had some pain in her knees, osteoporosis again, so quite weak bones, heart failure and chronic kidney disease. So she had multiple morbidities, multiple long-term conditions. But she wasn't on too many medications. She was on furosemide, which is a diuretic for her heart failure, alendronic acid, which is strengthens the bones, and we'll talk a bit more about that later in the session, and some paracetamol for the pain in her knees. Now, she had some increased pain in her knees, which stopped her getting out and about. So she went to see her GP, and he described diclofenac, which is a non-steroidal anti-inflammatory drug, non-steroidal anti-inflammatory drug, which really is very effective for pain. It helps the inflammation, but it also is a very good analgesic. But unfortunately, the GP didn't set a review date for this analgesia, so the medication got put onto Dorothy's repeat prescription. Now, obviously, Dorothy's knees felt a lot better, the pain was better, so she carried on taking the medication. After about 3 or 4 weeks, Dorothy started to develop some indigestion, and she thought, well, it's quite normal for my age, and she went to the supermarket and she bought some Rennies, so something just to help her indigestion. Unfortunately, that day, Dorothy collapsed and she vomited blood. Hematemesis is vomiting blood. She then collapsed and was very dehydrated. Now, what had happened there is the non-steroidal anti-inflammatory, one of the side effects of that is irritation of the stomach lining, gastric irritation. So she's gone on, they're fine in the short term, a few days that would have helped, but to go on taking them is quite dangerous in frail older people. So she lost a lot of blood and therefore she collapsed due to dehydration. Unfortunately, when she fell, she fractured her hip. Now, she'd already had osteoporosis, she was already much more at risk to a hip fracture. Unfortunately, she lay on the floor all night and she developed a grade 3 pressure sore. When she was found in the morning, the paramedics were called and she was admitted to hospital, and she was thought at the time to have an infection in her pressure sore. She needed to go to surgery in the next 48 hours to have her hip pinned and plated, so she was given some broad spectrum antibiotics because it's obviously dangerous to operate on someone with an open wound with an infection. Unfortunately, because she was prescribed the broad spectrum antibiotics, she developed Clostridium difficile diarrhea, and she became more dehydrated after surgery. Unfortunately then, Dorothy's kidney and heart failure worsened and she ended up with multi-system failure and she died. Now, some of those things may have happened anyway, we don't know, but really that's just to demonstrate to you the dangers really, I guess, of just adding in one more drug. Things that we would expect to be really safe, and Adele and I have had a conversation this morning about taking Nurofen, which is a non-steroidal anti-inflammatory, because we're both feeling a bit stiff and creaky this morning. But in a frail older person, that can really make a difference to them, and it can really increase their frailty, and in this case did lead to her dying. So always think about polypharmacy in older people. What do you think is polypharmacy? How many medications do you think it takes to define polypharmacy? Just type in the box for me. Yeah, we've got a 4, we've got more than 3, more than 4. Any other thoughts on that, or is that what
Higher,
everybody thinks?
lower.
Higher, lower, yes. A bit 3 plus, more than 1, yeah, yeah. Okay, well, I mean, the accepted definition is 4 or more, but I think it very much depends on the person and on the medications they're taking. I would always want to see a medication review on an older person. So if you meet an older person, always have a look at the medications they're taking and think about, are any of those culprits that could lead to falls or further deterioration, or maybe just doing more harm than good at that stage. On the whole, we don't prescribe medications as nurses, although many of us now are independent prescribers, but I think we all have a role in ensuring that patients take medication safely and effectively. And this is just a few things that I think we should think about, really. So think about, is every medication essential? And if it is essential, is it being taken as prescribed? Because many, particularly older people, don't want to tell the prescriber that they don't want to take the medication or it's giving them side effects, and sometimes they'll just stop and maybe then just keep the medication in a cupboard, and as the prescriber we might think they're taking that medication but they may not be. It is very difficult then to get a true clinical picture of what's going on. So build that relationship with patients and just talk about their medication. You know, are they taking it as prescribed? Can they remember to take it as prescribed? I know if I even have to take a course of antibiotics, it confuses me. So sometimes some of these medication regimes are incredibly complex. Think about problems the patient might have taking the medication. Can they open bottles? Can they access blister packs, etc.? Are there different solutions? Are there once-a-day medications that might be easier? Always think about simplifying medication regimes. Think about side effects, and we can't know all of the side effects of all medications, but there are certainly some that you might want to become more familiar with older people. Think about providing written medications. You know, people respond really well to medication charts that they can tick as they've taken it, etc. That often just helps people to take things effectively. Just talk to the patient about, do they understand? Do they know why they're taking their medication? If they understand and know, they're much more likely to be concordant with that regime. And always think about any cognitive impairment, because we may think that people are understanding their medication and taking it effectively, but they may not be. So always think, is there any confusion there? So just to summarise that part of the presentation, polypharmacy is incredibly common in the management of multiple long-term conditions. We know that polypharmacy and its effects are compounded as we get older. The effects of ageing on our body mean that we don't respond in the same way to drugs as we did previously. So we need to think about that, and a drug that someone took at 50 may not have the same effects when they're 70. So certainly look at long-term medication at that point. We all have a responsibility to ensure that people are taking their medication safely, and where polypharmacy is necessary, because some people do have to take multiple medications, we should always act to minimise the risk and maximise the benefits, and always do that in partnership with the patients. It's the patients that have to take these medications, and it's their life that we're going to be impacting on. So it has to be what they want to do, so very much a partnership approach. So any questions on that part of the presentation before we move on? Yeah, any guidelines for polypharmacy and long-term conditions? Yes, definitely. The Welsh Health Board have just produced a very good guide on polypharmacy and older people. I'd recommend you to Google that and have a look. In terms of a medication review tool, there's a tool called the Stop-Start tool, which some of you may have already come across. We use that very extensively in Cornwall, and it really helps you to focus on older people taking multiple conditions and what are the likely drugs that may cause problems. So it's called Stop-Start. So just Google that, have a look at that one. Certainly recommend it. We've also just developed a toolkit for frailty in Cornwall, which is available now for all clinicians in community and primary care. And I'm really happy, Adele, if you want me to email that to you.
That would be fantastic.
And then the students can access that, because that's got case-finding tools in it, it's got a CGA template, and it has the Stop-Start medication review tool.
Yeah,
so
that would be fantastic.
More than happy to share that with you.
We can put that on Moodle for the students.
Fantastic. Yeah, I'll do that.
Kim's has actually said that if you feel that the frailty is relevant, frailty tools, especially some of the newer things that Helen's been briefing us on, relevant to your assignment, then please go ahead and look at that. So we're going to move on now. We haven't finished yet.
No. Right, the second part of the presentation, what I wanted to talk about really was the problems of falls. Now, as part of my clinical work, I run a clinic alongside a consultant geriatrician, and we see older people who have falls. And we've already said that falls are a really important indicator of frailty, but they're also a result of increasing frailty, particularly linked with poor mobility and balance. So I'm going to talk a little bit about falls. I'm going to just talk about syncope, which is, we think of it as fainting, but it's sudden loss of consciousness. And something, again, which is very common in older people. Often older people just find themselves on the floor and don't quite know how they've got there. And there are often underlying medical conditions that we can consider there. And we'll very briefly consider osteoporosis because, as I've already mentioned, the worst thing that can happen for a frail older person is to fall and fracture, because that is a real threat to their independence and being able to live independently in the future. So what we're going to talk about today are those things really, the impact of falls, what are the risk factors for falls and the causes. I'll talk a little bit about accidental and mechanical falls because I see a huge amount of referrals in the clinic around, people had an accidental or a mechanical fall. And I would argue that in frail older people, very few falls are accidental. There are normally underlying causes that we can intervene and impact on. We'll talk about some of the common medical causes, how we find out why people are falling, some of the investigations. I'll show you the nice guidance on falls, but you can look at that as well if you're particularly interested and if you're covering people who fall in your case studies. And we're going to cover osteoporosis. So, the scale of the problem. Now, the information you've got on your screen now comes from the National Service Framework for Older People, which goes back to 2010, so we're 15 years ago this was published. I remember this being published, which shows how old I am, but when I look at some of those facts and figures there, they really ring true now. I don't think any of that has probably changed and maybe has got worse. So we know that falls lead to A&E attendance. We know that it leads to an awful lot of people fracturing their hips and also dying. Osteoporosis plus falls lead to fractures, as I've already said, and we know that falls are a really common cause of admission to long-term care, so wanting to go into a care home or needing to go into a care home. But we also know that falls are a common symptom of unidentified health problems. So there are things that we can do to stop people falling or to minimise the problem, and we should always try to do that. This is bringing this a little bit more up to date. This is a much more recent study by Age UK, which is a really good study. I'd urge you to go onto their website and have a look at it. We know that people over 65, 1 in 3 fall every year, so 3.4 million people over 65 suffer a fall, and it's the most frequent and serious type of accident in people aged 65 and over. So really common but really serious. And the main cause of disability and the leading cause of death for people aged 75 and over. Sometimes don't think we appreciate that. We often minimise, well, it's just a fall, isn't it? It's just a little slip or a little trip. People say that to me all of the time. But I think, we really need to consider the impact on older people of falling. And it's not just about what happens to them physically. Falls destroy quality of life. They destroy confidence. They increase isolation and they reduce independence. And this is what I see week in, week out in my clinic, is that people are starting to fall. It absolutely destroys their confidence. I saw a lady on Friday who was tearful throughout the consultation, and it was because her confidence had gone. She'd had 2 or 3 falls, not that many, but her confidence to go out and interact had just gone. She didn't feel she could do that anymore. And prior to her retirement, she was a farm worker. She lived a very full and active life, and suddenly she's afraid to go out of her door. So it's really that psychological impact. And the fear of falling is sometimes worse than the fall itself. This lady had 3 or 4 falls, nothing serious, no serious injury, but she was so afraid, and it's that fear that really causes the issues for people's psychological and mental health. In terms of consequences of falls, I tend to divide them into 4 things really. So physical injury, psychological injury, social injury and death. Physical injuries, well, we know that fractures, as I said, can be quite catastrophic, but also just soft tissue bruising, pain. Often the pain takes a long time to go away, wounds are very slow to heal. And then of course you've got the much more serious things like people that have fallen onto a fire or onto a radiator and burnt themselves. People often have spinal cord injuries and of course head injuries as well. We've already talked about some of the psychological injuries, but also the social injuries around that increased anxiety and what that then does to their ability to live at home, but also their carers' ability to support them. It often, when people start to fall, there's increased demands on carers' time, and they may need to move to a place of safety which may separate them from their family and friends. But also falls lead to death, as we've already said. That can be as a direct consequence, so someone falling over, knocking their head and having a subdural hematoma, so a bleed around the brain. But we also know that 25% of people that fall are dead within 1 year of presentation. And it doesn't matter what they fell, what happened when they fell, what the consequences of that were. And that's because falls are often a symptom of an underlying condition that maybe we're not treating adequately. Sorry, the screen doesn't seem to be moving on there. There we go, it's going now. And also just to think about as well the consequences of what we call a long lie. So a long lie is defined as remaining on the floor for 1 hour or more after falling. What we know is if people lie on the floor for more than one hour, they're much more likely to develop pressure sores, hypothermia, they may have hypostatic pneumonia. But we also know that 50% of those people who lie on the floor for more than 1 hour are dead within 6 months. And that's plus or minus any injury from the fall. So it really doesn't matter if they're injured or not. 50% of those people, if they've laid on the floor for 1 hour or more, are dead within 6 months. So these are really serious consequences. And again, like frailty, prevention is much better than cure with falls. If we can prevent people falling, we do them a really good service because of these really serious consequences. Just to go back to what I showed you right at the beginning, the National Service Framework for Older People in the year 2000, this is what the government at the time said that we needed to do. We needed to ensure that older people had effective treatment and rehabilitation. Their carers needed to receive advice on prevention through a specialist falls service, and that the NHS, working in partnership with councils, need to take action to prevent falls and also other injuries and resultant fractures. Have we done that? I don't know. Maybe we have. I think we've moved on, but I think we have very patchy falls services at the moment. So I just want to think a little bit around accidental falls. Some of the evidence out there says that between a third and a half of all falls in older people are accidental. But are they? If you start to dig a little bit deeper, you'll probably find that most accidental falls, as they're termed, stem from an interaction between a hazard, so something in the environment, but also the increased susceptibility of that hazard from the accumulated effects of age and disease. Now, what that means really is that as we get older, our balance becomes poorer, our muscles are not as strong, we don't have the ability to respond as quickly, so our reflexes, our corrective reflexes aren't as strong as they were. If we then meet a hazard in our environment, like an uneven pavement, say, or a rug on the floor, we don't always respond as quickly as we would have to that hazard. Now, we might say, well, that's just getting old, but what I would argue is there are things we can do about that, and it goes back to what I was saying about preventable components of frailty. If we intervene at that point to improve people's balance, to improve their muscle strength, we can start to think about how we might prevent falls. So never label a fall as accidental, I would say. Always just dig a bit deeper, carry out a falls assessment, and we'll talk a little bit about how we might do that. I think I've pretty much covered this. Often people come into my clinic and say, well, what do I expect? What can I expect? I'm 85, it's my age, dear, isn't it? And often they've been told, yes, it is your age. And there is something in that. As I've said, you know, things change. We also have impaired vision, we have impaired hearing, we have impaired memory often. But there are still very preventable elements of falls that we can consider and support people to work on.
And varifocal glasses.
And varifocal glasses. I always say varifocal glasses are the work of the devil. People love varifocals because you only have to wear one pair of glasses, or bifocals are exactly the same for reading and distance. What they do is they ruin your depth perception. So if you are already struggling, perhaps with lifting your feet as well as you did, or you already have poor balance, or you're not as steady on your feet as you were, or your legs are not as strong as they were, varifocals contribute to your ability to stay upright. So I do always talk to patients about that and ask them to consider maybe when they're having their eyes tested next to think about 2 pairs of glasses, but people do love them. So it's quite hard sometimes to get them to understand that. Someone's just said, I think, shouldn't that be assessed by the optician? Absolutely, yes it should. And I always say to people, you know, eyesight is, again, a real contributor to falling. Often people's eyesight declines quite slowly, so always recommend that people go and have their vision tested. But again, when you're assessing patients, there are some really simple questions that you can ask. So I always ask if you saw your carer or the person that's come with them to the clinic across the road, would you know it was them? And if they say no, then their distance vision is a problem. You can ask them, can they read up close? So again, you're thinking about their near vision. And I always ask about if you're making a cup of tea or filling a glass, do you ever overfill the cup? And that can test their depth perception. So 3 really simple questions.
But the other thing with opticians don't assess people for falls, the older person, do they? They don't. Think about it, if you can buy 2 glasses for 2 for 1, it's actually cheaper to have a distance set and a near sight set than it is to have varifocals. And of course, at the end of the day, your optician may be absolutely lovely and you really enjoy the relationship that you might have, or the fact that they take time to give you advice. They're in this world to make money, and making money out of varifocals is actually, you know, 2 pairs of varifocals, the price of 1 is a lot more expensive than near and distance sighted kind of thing. But they don't. They'll look at the distance and your near sight reading and decide what lenses have, but they're not going to say, you know, and how are you when you walk downstairs? Can you see clearly? Because I've got varifocals, and I certainly, you know, when I start walking downstairs, I think, damn, I'm looking through the near sight bit at my feet and the steps, and I've had to think about, you know, walking down steps at railway stations and things like that, because the varifocals don't help that. And also what's prompted me to think about it, as well as Helen talking about it as well, and I don't like to think I'm old and frail quite yet, but if a younger person's thinking that it's difficult to see properly when you're walking down steps, you know, older people as well, and it's trendy to have varifocals.
Yeah, and it is easy, isn't it? It is easier to have 1 pair of glasses, but you know, if we have varifocals, we still have very good corrective reflexes. If we suddenly were to misjudge depth and stumble, we'll correct that. Older people, as their reflexes become less able, they lose that ability. So a stumble for them will be much more serious than a stumble for us, really. So, okay, so we've talked about that, so I'll move on from that. So we've talked a little bit about sort of balance, and we've gone on to varifocals, because I always do, it's my soapbox. But there are many causes of falls and fainting or finding themselves on the floor in older people. How many causes do you think there are? Just give me a number, go on.
Causes of falls?
How many numbers of falls? How many numbers of causes of falls? 15, yeah. Any more? Anyone think there are more than that, less than that? Okay, no advance on 15. Well, there are many causes of falls. Myself and a colleague, a geriatrician colleague, sat down and tried to list all of them, and I think we got to about 150 causes of falls. And that's the issue, I guess, with falling, is that it is multifactorial. There's usually not one thing that makes an older person fall. And that's why falls are so modifiable, because often you can do lots of little things to modify their risk factors rather than doing one big thing. So in terms of a specialist falls clinic where I work, these are the sorts of things that we tend to work on. So we try to think about what are the risk factors for that particular person and mediate for them if possible. So if we can modify those risk factors, that's good. But if not, then we'll try and find a way that the person can live with those risk factors more effectively. Always think about treatable causes and treat them, because it isn't just your age, dear. There are often things that can be treated and that we can do to make a big difference. We also try to establish some coping strategies, because we've talked about psychological consequences, and people often, despite everything that we do and everything that that person does themselves, they will continue to fall. So we support them to develop coping strategies, to be more psychologically robust and be able to interact as best they can. For example, if people are continuing to fall, we'll teach them to fall safely and we'll teach them how to get up again. So sometimes you can't always prevent falls, but you can prevent the injury from falls if you can. And we also will always try to identify and treat osteoporosis, because osteoporosis is very undertreated at the moment.
I've just got this mental image of people, you know, people do stunt teaching a load of old people how to roll around and get up.
Roll around and get up and fall. Yeah, that's what the physios do in the clinic. It's fantastic. Really, really good work. Yeah.
Sounds like fun.
It does. So in terms of how we carry out a falls assessment, and we do this at the Falls Clinic, but this isn't something which is a specialist approach. Most of this can be done within your comprehensive assessment that you're carrying out on a frail older person. And what I would suggest you do is focus on those 4 things there really. We summarise it as DANE. So drugs, always think about polypharmacy, think about the effects of ageing and what's going on there, think about any medical conditions that are underlying that person's falls, and also think about the environmental aspects, so the hazards, the environmental hazards that perhaps we can support people to live with more safely. So in terms of what we do at the Falls Clinic and what you may want to do when you meet an older person that's falling, always take an effective history. When I see new patients, I see them for about an hour, because it's really detective work with falls. You need to really understand what's going on for that person. So how many falls have they had? What's happening when they fall? You know, are they falling outside? Are they falling inside? Do they just find themselves on the floor, or did they trip? Try to get a witness account if you can, particularly if the older person doesn't know themselves. Often people say to me, I'm just on the floor. I don't know how I got there, but suddenly I was on the floor. 1 minute I was up, 1 minute I was down. That's quite difficult, because you don't really know what's going on, but sometimes people would have seen them fall, and that really helps. And what I'm particularly thinking about is, did they just fall, or did they stagger? Did they just drop to the floor? And prior to that, did they look uncomfortable? Did they say they were in pain? Were they sweating? Were they pale? Because if they do faint, often some of those things become very obvious to that person who's watching them, but the person themselves wouldn't necessarily know. Were there any injuries? So I'm thinking about things like fractures, facial injuries versus arm injuries. What I'm thinking about there is, if someone falls onto their face, they haven't put their arms out to save themselves. And putting your arms out to save yourself is a reflex action. And often people come in with a wrist fracture because that's exactly what they've done. So that person with a risk factor knew they were falling. The person who comes in with black eyes and a smashed nose didn't know they were falling over. So something happened to precipitate that, really. I always ask people about dizziness, and dizziness is incredibly subjective. What I think is dizzy is not what someone else would think is dizzy. So I try to get people to describe it a bit more in detail. Particularly what I'm interested in, is there a true sensation of vertigo? And vertigo is a sensation of movement. So often people describe it as they're standing still and things are spinning or moving around them. Vertigo is important because vertigo is often connected to problems with the middle ear, which can very easily be corrected. And often people spend many years suffering vertigo and falls when something very simple can be done to address that. So always ask about dizziness, always ask about sensation of vertigo. Always ask about palpitations. People don't always understand what palpitations are. So I generally say, does your heart feel like it's beating very fast or in an irregular rhythm? And obviously, do people experience any chest pain? Do they have any chest pain before they fall? Other things I would want to be thinking about is any neurological symptoms. So when they fell, did they bite their tongue? Were they incontinent? If they did, that's more likely to be a fit than just a straightforward fall. How did they feel afterwards? Often when people faint, they might feel a bit odd for a few minutes afterwards, but they generally make quite a quick recovery. If people have a fit, there's often a period of time for several hours afterwards where they feel really quite unwell. So it's just trying to distinguish between those two things. And always do a full systemic inquiry, so always asking questions about the cardiovascular system, the genitourinary system. Often people fall because they're running to the toilet very quickly because they have urgency, incontinence. Musculoskeletal symptoms, again we've talked about pain but also stiffness in the joints and the muscles. The central neurological system, so vision and hearing is really important, we've already said, but also do they get any numbness, tingling, heaviness in their arms and legs? And also we've talked about already the psychological impact of falling. And yet more. Drugs, we've talked about always review medication, and I'm thinking particularly if people have lots of medication to lower their blood pressure. Also, if they have strong painkillers, things with codeine in, opioids, they often lead to people falling. Other things like diuretics, because again they lower blood pressure, and also things that help people to sleep. So often you'll find older people that are still taking quite strong sleeping tablets. They will always have an impact in the morning. And often many of the things now that are given to treat neuropathic pain, so things like amitriptyline, gabapentin, they work very well for pain relief, but they will always give older people a hangover effect in the morning and make them more likely to fall at night because they have a sedating effect. So think about those particular drugs when you're assessing. We want to know what's happening in terms of long-term conditions, so always ask about cardiovascular history, neurological history, strokes, heart attacks, diabetes, and have they already had fractures, have they already had hip replacements, etc. Social history, smoking is important, and of course alcohol is important, and older people actually drink quite a lot of alcohol. I always ask about it in my Falls clinic, and I'm never ceased to be amazed about how much alcohol older people drink. And I think it's an increasing problem. I think with social isolation, people are using alcohol to either help them to interact socially or else as a crutch for their loneliness. Don't think because people are over 75 or over 85 they don't drink alcohol anymore. People do. So always ask very sensitively about alcohol. And then just thinking about how is this impacting on their daily living. If they're not worried about falling and if it's not impacting, that's fine. But for most people, this is really impacting on their ability to interact and to function daily. We would always carry out different examinations at a Falls clinic, and these are the sorts of things that I'm particularly interested in. So always take the pulse. It sounds very simple. It sounds very, I don't want to teach you to suck eggs at all, but always take rate and rhythm. And because we want to know if there are any underlying heart arrhythmias. So does the pulse feel regular? And is it going fast or is it going slow? Very important. I would always listen to heart sounds. It may be something which you're not familiar with doing now, but I would listen to heart sounds and listen for any murmurs because, again, I'm thinking about underlying heart conditions. One thing that you can do for your frail older people that is very effective is postural blood pressure. So always take lying and standing blood pressure. I would say in everyone over 75 if you possibly can. It's very important, and a blood pressure drop when you stand up leads to falls, and many of the drugs we've talked about cause postural blood pressure drop. The gold standard is to have people lying down for 15 minutes and take their blood pressure, to have them stand up and to take it immediately, and then to take it at 1, 2 and 3 minutes. And the reason for that is, for some people blood pressure doesn't drop immediately on standing, and those are the really unlucky patients where they stand up, they feel fine, they walk into the kitchen to make a cup of tea and then they fall over. And that can be really quite difficult to pick up unless you take blood pressure systematically at 1, 2 and 3 minutes. So I'd urge you to do that with your frail older people. I'm thinking about your assessments for your patients within your case study. That's important, I think. Neurologically, I would carry out a full neurological assessment, but there are really simple things that you can do. Watch the patient walk. How are they walking? Are they unsteady? Do they walk with a wide-based gait? What's their step length like? Is it normal? Is it short? Are they staggering? Are they leaning to one side? Do they become more unsteady on turning? Really simple things that we can all do but are really important. And again, we've talked about vision, but always think about visual acuity if you can. We carry out quite a few investigations in a falls clinic, but we would always want to take some blood from a patient, and we're particularly interested in things like, are they anemic? Is their renal function okay? Are they more dehydrated? I'd want to think about thyroid function, because people that have an underactive thyroid are much more likely to fall. And I'd also want to think about things like B12 and folate. Having low levels of B12 and folate in the blood cause neurological problems. It causes people to have numbness of the limbs, and it also causes people to be more unsteady on their feet. So always think about just taking some baseline bloods if people are falling. We always carry out a 12-lead ECG. And what I'm particularly interested in the ECG are conduction deficits. So do people have arrhythmias? Do they have atrial fibrillation, for example? Do they have tachycardia? Do they have bradycardia? And do they have things like heart block? Because if people start to develop particularly second and third degree heart block, they're not conducting through from one end of their heart to the other properly, and they're much more likely to feel dizzy, to feel unwell and to fall. If I find an abnormality with 12-lead ECG, I might want to think about a 24-hour ECG. And what I'm looking for again is the heart going too slow or is the heart going too fast? That's all I'm looking for. And significant pauses in ECG are anything above 3 seconds. And then if you're having a tachycardia that's lasting more than about a minute, that's significant on a 24-hour ECG and may well be contributing to falls. So those are the sorts of things we should be looking for. 24-hour blood pressure is important because I might want to start taking away people's hypertensive medication, but I don't want to do that if they already have a high blood pressure. I can't really judge that in a clinic setting, and probably when you first meet a patient that's quite hard to judge. So a 24-hour blood pressure recording will give you a better picture. Occasionally I will scan people's heads, that's if I think they have cerebrovascular disease developing, or particularly any problems with their cerebellums. The cerebellar disease is very highly correlated with people feeling unsteady and off balance and uncoordinated. So might want to do a CT head. A DEXA scan helps us to look at people's bones to see if they have osteoporosis developing, and I often do that. Carotid sinus massage and tilt table testing. The picture you've got at the bottom there is a poor man on a tilt table test. That's a very useful test if people have postural hypotension or we think they have problems with their heart rhythm. And what we do is we strap them to a tilt table, which is the bed you've got there. We lie them flat and then we connect them up to a beat-by-beat heart monitor and a beat-by-beat blood pressure monitor. So it helps us to really monitor blood pressure and heart rate very, very closely and systematically. We then move the table up. So we move them from lying flat to standing up on the table. And if they have a postural drop or they have a problem there with their heart slowing down, that will happen at that point and we can see it. We can then massage their carotid sinus, which is a little area on, I'm just pointing to it on the webcam if you can see me, on their carotid, over their carotid arteries. So just here. Don't do it now, you don't want to make yourselves faint, but you can massage an area there on their carotid artery, which will replicate their symptoms. So it will slow their heart down or it will drop their blood pressure. So we'll often do that in an arena where we can control that if that becomes a problem. So alongside a tilt table testing, you always need to have resuscitation equipment. And I have carried out a tilt table with a colleague where we stopped someone's heart for 9 seconds, and that was a bit scary. So it did start again, that was fine, but you do need to have resuscitation equipment there, so I wouldn't recommend trying that on yourselves or on anyone else. And we also use telehealth quite extensively now for people that have dropping blood pressure. So what we can do is put telehealth equipment in the patient's home, and the person themselves can be taught to monitor their blood pressure effectively, lying and standing. And if we do that over a couple of weeks, we can normally see if people have a postural drop. We may not pick that up in a clinic setting. You're much more likely to pick that up in someone's home. So we use telehealth quite extensively now too. So those are the sorts of investigations that we might want to do in a falls clinic, and if you refer for a falls investigation, a falls clinic assessment, these are the sorts of things that we're likely to do. There are now NICE guidance for falls. In fact, they're quite old now, 2004, and they're just under review at the moment. And these are the sorts of things that the NICE guidance recommend and that have the best evidence. So things like case identification, well, you would expect that, wouldn't you? You need to know people are falling. That multifactorial comprehensive assessment has a really good evidence base to it, as does multifactorial intervention. So it goes back to doing little things, lots of little things, rather than one big thing. Strength and balance training is really important, and our physiotherapy colleagues are absolute experts in this, and I'd recommend you spend some time with a physiotherapist seeing some of this if you can, because the difference that balance and strength exercises can make are huge and can be assessed really objectively. Home hazard intervention's got a good evidence base, so someone going into a person's home and just checking are there any hazards, and then if there are, working with the patients to address those hazards.
Who would do that?
Generally that's done through an occupational therapist. Yeah. So physiotherapists and occupational therapists often work together, but OTs are the people that would go into the home and do that. Okay. Thinking about medication review, we've talked about that extensively. Always review medication and always withdraw medications that are contributing to falls. Of course, cardiac pacing has a good evidence base, because if you do have a person that's got a very slow heartbeat or they have a heart block, you put a pacemaker in, you cure the problem. So obviously cardiac pacing is a good thing to do for that group of patients, not all patients. And education has a really good evidence base. If people understand why they're falling and what they can do themselves to address that, then that really helps, as you would imagine, and has a good evidence base. I know this is a really busy slide and I'm not going to linger on it, but it's just to show you that if you have a look at the NICE guidance, this is the patient referral and care pathway. Now, this is the national NICE one. In the areas that you're working, you will find there are local referral protocols and pathways. So worth asking the clinicians you're working with, you know, what is the referral pathway for the falls service in your area, and what are the falls assessments that are carried on prior to referral. So that's where we are with falls. Does anyone have any questions before we move on to osteoporosis? We'll give you a couple of minutes to think about that and type me any questions in the box. Takes a little while to type. Yeah. We're just giving it a minute or so just to make sure any questions are coming through. We've got time, so we're okay. Any questions about the falls assessment, causes of falls, things that we can be doing? Yeah. Okay, so no questions coming through there, so we'll move on to the final part of the session, which is just really to highlight osteoporosis for you, because osteoporosis is incredibly common, but it's also incredibly underdiagnosed, undertreated, and again, really significant in terms of people who are falling. If they fall and fracture, it has a much higher impact on their ability to live independently following the fall. So you've got a few facts and figures there. 1 in 3 women over 50 have osteoporosis. So really, really common. 1/3 of women over 50 have osteoporosis. It's thought not to be a problem in men, but actually it is still a problem in men. 1 in 12 men over 50 have osteoporosis, and almost half of women have an osteoporotic fracture before they're 70.
Do you think that's likely to increase, 1 in 3 women?
I think it will increase. I think it's going to increase for a couple of reasons. The fact is we're all living that much longer, so we have much more time to become osteoporotic. But also, certainly in the last 10 to 20 years, we've very much reduced the use of hormone replacement therapy, because as women we have a protective effect of estrogen, the hormone that we have as women, until our menopause, until we're 45 or 50. Estrogen helps to protect us against osteoporosis. Now, once estrogen goes, once we've had the menopause or starts to reduce, we're much more likely to have osteoporosis. We used to replace that with hormone replacement therapy for a lot of women, but we don't do it as much now because of the side effects of hormone replacement therapy. So I think we'll see more.
I also think about the healthy thing around drinking milk being good for you
Yes.
as young people, but that still affects you in older life, and school milk was stopped a few 50 odd years back.
Yes.
And so, well, not 50 years back, about 40 years ago. So that I also wonder whether there's this sort of removal away from that health promotion kind of thing that we had as youngsters around how good milk is for you. You just don't see that kind of thing anymore.
No, you don't. And also that move away from dairy products. You know, sometimes we've moved away from butter, milk, cheese because of high fat content, but they are really important sources of calcium. So I think we may well. I think certainly dietary factors will make a difference. Yeah. So that's just a few facts and figures. Osteoporosis, the definition is just that, porous bones, so having more porous bones. Now the diagram you've got there, the studies that have been done on osteoporosis have been done predominantly on rats, so that's why you've got pictures of the rats at the bottom. And obviously the rat life cycle is about 12 to 18 months, so for us that translates, into years. But this very much applies in people as well as rats, but most of the studies have been done on them. So as we get to about 18 years old, our bone density is increasing all the time. So we're laying down bone, we're making our bones stronger. So up to 18 and then on to 25, that's the time we're laying down our bone and we're increasing our bone density. Now that starts to level off between 25 to 35 and then starts to drop off from 35 onwards. And then when women have the menopause, then bone density starts to drop off much more steeply. And there comes a point in that bone density trajectory where there's a fracture threshold. So if people fall at that point, they will break a bone. So it's knowing where that fracture threshold is and delaying that threshold as much as possible. So keeping our bones as healthy as possible for as long as possible. This is the science bit, and I'm not going to labour on it at all. You can look at this if you want to in more detail. But we have two sorts of cells in our bones. We have osteoblasts that make bones grow, and we have osteoclasts that reabsorb bone. And they work in tandem all the time, so bone is always being laid down and being reabsorbed. But as we get older, the osteoclasts tend to take over a bit more and absorb more bone. So you've got that gradual progressive loss of bone density that I've already mentioned. So the inner part of our bone tends to increase, so that cavity in the middle increases, the outer layer becomes thinner, so much more likely to break, and our total bone diameter expands. So basically think of it really as thinning of the bones, I guess, and the bones becoming more holy. As a few facts and figures there again, we do have some bone loss from the age of 35, but then it very, very much increases from the menopause. So if you're a woman, you get to about 80, you would have lost 30% of your bone mass by that time. And a man aged 80 would have lost about 10%. So it's still significant. There are still significant and very significant in terms of when you'll reach that fracture threshold. Other risk factors for osteoporosis. Just quickly type in the box for me any other risk factors you think there are. We've already talked a bit about diet, but anything else you think can lead to osteoporosis developing more quickly? Just type me in the box any that you can think of. That's a good one. Yeah, we've got lack of vitamin D coming through. Yeah, absolutely. Calcium and vitamin D go hand in hand. Yeah, steroids, so taking long-term steroid medication can very much be a risk factor for increasing osteoporosis. Immobility, yeah, not enough exercise, particularly not load-bearing, weight-bearing exercise. Early menopause, you're absolutely right. Yes, if people have menopause much earlier, they haven't got that protective effect of estrogen. Comorbidities such as COPD, yes, because people with COPD are much more likely to take steroid medication. So yes, there's certainly something in that around long-term conditions where people may have to take long-term steroids. And when I say long-term, I mean 3 months or over.
I think also working in that field, I've come across many people in their sort of 30s and early 40s, because they've had steroids for a long time. They're taking calcium supplements, and certainly I've cared for people who have with severe COPD or asthma, because the same thing applies. Asthma problems. Sorry, they're the younger ones, not the COPD patients. So the younger people with asthma are so depleted that their risk factors of falls are even higher, and their mobility is reduced, as well as all those other things that steroids do to you. And you can see it in the younger people with asthma. Sorry, it triggered me thinking about asthma and COPD as well.
Yes, yeah, you definitely do, yeah. And also you might see it now in older people that have had rheumatoid arthritis, because steroids used to be a real standard treatment for rheumatoid arthritis. Not quite as much now, but often people have taken steroids for many, many years. Malnutrition is an interesting one. We've already talked about calcium, but there's a bit of evidence now really around poor nutrition, particularly in the teenage years. So late childhood to teenage years, poor nutrition generally at that time can be a risk factor for osteoporosis in later life. Caffeine and alcohol, absolutely, yes it does. They are two important risk factors, and the other one along that in terms of lifestyle is smoking. Smoking is a strong risk factor for osteoporosis. Yeah, and someone's just put that now, fantastic. Parathyroid affecting calcium in the bones, yes, definitely. If you have a person with osteoporosis, you'd always want to check parathyroid hormone levels. Low levels can affect bones. So yes, there's a definite link there as well. So I think you've got pretty much all of those, haven't you? I mean, we haven't talked about age, but obviously we've already said that age is an independent risk factor. As we get older, nothing we can do about it, but we're much more prone to osteoporosis. Female, we've talked about. Yeah, maternal hip fracture is an interesting one, but it is an independent risk factor for osteoporosis. So if your mother broke her hip, you are more likely to have osteoporosis. So something to ask your patients. Patients always say to me, why are you asking me that? What a strange question, but it is important. So something to ask.
It seems a strange association. I can't work that one out.
I think it's because your mother probably had osteoporosis too. But when our mothers were breaking their hips, they weren't necessarily diagnosed. So it's been shown to be an important risk factor now.
Yeah.
It's not all of those. Carbonated drinks. Yes, there's some evidence coming through that carbonated drinks are a risk factor for osteoporosis. Don't think we've got full evidence yet.
And that's again that age thing we were talking about earlier. Is that the generation that are in their 50s today were that generation that were on the old Coca-Cola.
Yeah.
And rotting teeth as well.
Yeah.
That's the other side thing. But you're going to get that's a potential increase. So I guess the evidence might grow, because sort of anybody who's 50 and below, 40s and 30s, and even today's younger generation, it's going to be really interesting, I suppose, to see those links.
Yes, it will be, yeah. And genes, yeah, you're absolutely right, goes back to the maternal hip fracture. There's not a huge amount of evidence beyond that, but if your mother broke a hip, you're much more likely to have osteoporosis. So worth thinking about. Clinical features. What do we think are the clinical features of osteoporosis? Type me a few in the box. How would you know someone had osteoporosis without looking at their DEXA scan or them telling you? What are the clinical features? Hunched over, yes, yeah. hunched over, we call that kyphosis, and it's a curvature of the spine. I think on the few slides back where we have the graph of the rat and the person, that lady had a kyphosis. Used to be called the dowager's hump. We've got a humped back there. Yeah, absolutely. Yeah, it's a curvature of the spine, and that's caused because the person's spine is crumbling. They have fractures of their spine caused by osteoporosis. Their spine becomes much weaker and it will bend more quickly. So generally you tend to see that kyphosis, that bending forward. You can also see a scoliosis, which is much more of an S-shaped curvature of the spine. But yeah, hunched over, humped back. Any others? Muscle loss, it's not a clinical feature, but if people fracture, they will very quickly lose muscle. So it is important, but not a clinical feature of osteoporosis. Rickets. Bowed legs, probably more indicative of rickets. Yeah. You may well have bowed legs or a misshapen look of the legs if you fractured, but not a clinical feature of osteoporosis. Any others? Okay, well, the main clinical feature is a fracture. And often people don't know they have osteoporosis until they've fractured, and that's the really sad thing, is that often the damage is done to a degree when we first meet people. That's a wrist fracture there, that's a very common osteoporotic fracture. So if someone comes to you and they've fallen and they've broken their wrist, you should think about, have they got osteoporosis? We've already mentioned the vertebral fractures. That may lead to the hunched back and the bending over, but it also often leads to loss of height. So people will sometimes say to you, I'm sure I used to be taller than I was, and they're absolutely right. Anything above 4 centimetres is a significant height loss and should be making you think, have they got osteoporosis? Hip fractures usually always mean osteoporosis, not always, but on the majority of people who fracture their hip will have an underlying osteoporosis. And the other fractures that are sometimes suspicious are neck of humerus, so the top of the arm, a very painful and difficult fracture to heal, or a horrible fracture for people. People who fracture their pelvis and also their distal, so lower down tibia and fibia, so things like an ankle fractures. And we often talk about low impact fractures. So if someone falls off a scaffolding 10 foot high and breaks their ankle, okay, that's not a low impact fracture. But I met a lady the other day who rolled out of bed and fractured her ankle. Now that's not right. You don't fall out of bed and fracture your ankle. That's a low impact fracture. So those are the things that should start to be raising your suspicion of osteoporosis. In terms of investigation, the only way to diagnose osteoporosis is a DEXA scan. So it's a bone density scan. You've got a picture there of someone having one. They do them in all the major district general hospitals. You can refer a patient for them. What it does, it scans the bone. Usually they use the hip bone, so the pelvis, and looks at what your bone density is in compared to the average person of your age. That's how bone density works. So usually if you refer someone for a DEXA scan, you'll get a really useful report back saying whether they have osteoporosis and what the suggestive management should be. You can also ultrasound people's bones, but it's not a validated test. We used to do it in general practice for a while, but it actually is shown now not to be as valid as DEXA scanning, so you won't see it used very much now. You should always think about excluding causes of secondary osteoporosis. So people have already mentioned parathyroid hormone, serum calcium. Always check those if you have a person you think possibly might have osteoporosis, because there could be an underlying problem with their parathyroid gland. And other bloods that you might want to think about are thyroid function tests. If people have an overactive thyroid, they will be more likely to have osteoporosis. Testosterone, a low testosterone in men makes them more prone to osteoporosis. ESR and immunoglobulins, they're just inflammatory markers. If those are raised, if people have fractures and pain in their bones with raised inflammatory markers, you should be thinking about malignancy, so underlying myelomas, etc. So those are the only tests and investigations around osteoporosis. But in terms of preventing it, what can we do? Well, there are again lots of things we can do. We've already talked about nutrition. Calcium and vitamin D is very important, and keeping an adequate calcium and vitamin D take is important. And calcium and vitamin D go hand in hand. You can't take one without the other. So calcium isn't absorbed well without the presence of vitamin D. So you need to think about both, and that's why when people take supplementation, they'll always take them together. So calcium and vitamin D always come in a combined tablet or drink, etc. We've talked about hormone replacement therapy post-menopause. It is still a really important treatment for osteoporosis, so people that already have osteoporosis, but it's not recommended long-term now because of the higher risk factors for cancer and heart disease for people that take hormone replacement therapy. And then you have prophylactic use of things called bisphosphonates if people are particularly treated with steroids. We've already talked about people taking long-term steroids. So what we would be concerned about is more than 7.5 milligrams of steroids, something like prednisolone, for 3 or more months. That's what we call long-term. Anything less than that isn't significant. If you have people that are taking that, they should be on long-term use of a bisphosphonate, and we'll talk about what that is now. In terms of treatment, this is the first-line treatments in the Cornwall and Isles of Scilly formulary. Now, if you work in Devon, have a look at the Devon formulary and look at their first-line treatments. They're probably pretty similar. Nice guidance underpins formulary treatments, so these tend to be quite similar. So first-line treatments are calcium and vitamin D and bisphosphonates, and then you've got second and third-line treatments. Now, the second and third-line treatments are generally only started in a secondary care setting by a specialist in osteoporosis management. Strontium you will occasionally see used as an alternative to a bisphosphonate. If people can't tolerate a bisphosphonate, they will take strontium. But the other treatments, raloxifene, parathyroid hormone, the different other, the anti-inflammatory type treatments, they are started in secondary care, usually by a rheumatologist. Those are the people that would tend to start that. So what I'm just going to talk about really are the common drug treatments, so calcium and vitamin D and the bisphosphonates, because you will see a lot of these in older people. So calcium and vitamin D is good because it's really cheap. NICE loves it because it's probably one of the cheapest medications out there. Have a look in the BNF. Calcium and vitamin D is literally pence every month to take. It's relatively well tolerated, although you will find a lot of patients who hate their calcium tablets because they're big tablets, they're hard to swallow. What I would say to you is there are many, many preparations out there. If people don't like calcium tablets, they can have a drink. There are different flavours of drinks. There are tablets you can chew rather than swallow. There are lots of things. There's no reason why you can't take calcium because there are many preparations. And you can even buy calcium toffees in Boots now. So if you really hate the tablets and the drinks, there are actually calcium toffees that you can buy if you fancy one of those every day. Calcium and vitamin D has to be taken with other osteoporotic treatments. So things like bisphosphonates will not work without calcium and vitamin D. So if you see a person on a bisphosphonate and they're not taking calcium and vitamin D, it's pointless them being on the bisphosphonate. They need to take them hand in hand. We've talked about patients on steroids. In terms of sort of population use, because often people say, well, why don't we just put everyone on people aged 75 and over on calcium and vitamin D? It's cheap, it's well tolerated, why don't we do that? Yeah. We don't do it because there is that link that I've mentioned already between high doses of calcium and heart disease. There have been some studies around that, but there is very good evidence for people in residential care to take calcium and vitamin D, and that's because we get vitamin D mostly from sunlight. So if you're housebound or you live in a care home and you don't get to go out in the sunlight very often, you're probably also not having a diet rich in calcium. Maybe you're not able to eat as well as you did, or perhaps the care home diet isn't as effective as it should be, or maybe you can't cook foods that are high in calcium. So there's a lot of evidence that if you're housebound or in residential care, calcium and vitamin D is a good supplement to take. But for other people, it's controversial. Bisphosphonates. Now the common bisphosphonates that you're likely to see, the most common one is alendronic acid, and you may well have met patients on alendronic acid, or alendronate is the other name for it. One of the trade names is Fosamax. There are others, etidronate, ibandronate, residronate, zoledronic acid. They've all got an 8, as you can see, they're all there. The key thing with bisphosphonates are they're a very, very good drug in preventing the breakdown of bone. They increase bone mineral density. They're shown to prevent osteoporotic fractures, and they have to be taken if you're on steroids. It's very important that people need to take those. So they're a really good drug. The reason there are lots of different preparations you can have different preparations to suit different people. So alendronate, for example, is a once a week preparation. So you only take it once a week. Quite convenient for some people to take that way. If people prefer a daily tablet, they can have it. That's fine. There are daily preparations. Ibandronate is actually an infusion of bisphosphonate. So if you have a person, say, for example, with dementia, that's falling, that has osteoporosis and really prone to fractures and needs a bisphosphonate but can't remember to take a daily or a weekly tablet, there's no reason why they can't be treated. They can go into a day hospital locally or into an acute hospital and have a 3-monthly or a 6-monthly infusion of ibandronate. And you're doing them a really big favour because you're keeping their bones as strong as possible. So often people think, well, there's nothing I can do, that person can't remember to take a tablet. I would argue there are things that can be done, and they are really important. So think about the preparation and what suits your patient, really. All bisphosphonates have esophageal side effects, so they're very irritant to the esophagus. When you take them, you have to take them first thing in the morning, and you have to sit up for half an hour after taking them, and always tell people to take them with a full glass of water. So that's why it's quite good to only have a once a week preparation, because you've only got to think about doing that once a week, really. Importantly, with bisphosphonates, effects are seen in the first 12 to 18 months. They're not effective beyond that. Now, I see a lot of people that have been on bisphosphonates for 10 years. They're not effective at that point, so you may want to think about, are they the most important thing for that person to be taking? You might be thinking about withdrawing them at that point. What I would also say is there's some very new evidence that's come out around bisphosphonates and spontaneous hip fractures. And they've shown that bisphosphonates now, when taken for longer than 5 years, can lead to spontaneous hip fractures. And that is a person just walking across the room and their hip fractures. So they haven't fallen, they literally just fracture. And I must put this into this presentation. I've got a really good x-ray of a lady that I saw that did just that, walked across the room, fractured her left hip for no reason. She'd been on bisphosphonates for 10 years. She had her hip repaired, she had some physiotherapy, she got back home, she walked across the room and her right hip went,
oh, never.
And it was just heartbreaking. So what I would say is, if you find people that have been on bisphosphonates for a long period of time, think about should they come off. Discuss that with the person's GP or prescriber. The nice guidance for osteoporosis are there. Do have a look at them. I find them quite confusing, I have to say myself. They're very long, they're very complex in that, for example, secondary prevention and treatment should be for people over 75 who have had a fracture, but people between 65 and 75 who have fractured and have proven osteoporosis should be treated. But then people under 65 with fractures, osteoporosis and an additional risk factor should be treated. The goalposts are always changing on drugs of choice, but bisphosphonates are still up there as first choice. So the nice guidance that are there, they are helpful, but they can be confusing. I would urge you to have a look at the FRAX tool. This is what I tend to use in clinical practice. Just Google FRAX, or you can follow the link there. It's a really useful tool. It's based on treatment guidance for the National Osteoporosis Guideline Group, not on NICE, but they are very, very similar. You're not going to go too wrong if you follow those guidance. What it does, you can type in information about the patient, so their gender, their sex, their age, if they have any risk factors for osteoporosis. You just type that into the tool and it gives you a very nice algorithm and picture of their risk of having a fracture in the next 10 years. So really simple and easy to do. What it also tells you is if that person should be treated or not. So I'd urge you to have a look at the FRAX tool. Again, something useful to think about in your case study if you've got a person who has risk factors for osteoporosis. Just type them into the FRAX tool and see what they come up with. So just summarising what we've said about osteoporosis, if you've got a person who's falling, always assess them for risk factors of osteoporosis. Effectively assess lying and standing blood pressure. If there's one thing you can do in older people that are falling, make sure that you find out if they're having a postural drop or not. Think about their gait and balance. Something like the get up and go test is really simple. Can they push up from a chair with arms, and how fast can they walk an area of the room? For example, if it takes you longer to walk 4 metres than 5 seconds, then you're frail. So if it takes you to go longer than 5 seconds to walk 4 metres, you are frail and much more at risk to falling. So think about objectively assessing gait and balance, and think about those medications that contribute to a falls and eliminate them as soon as possible. So that's, I suppose, my top tips really for older people that are falling. Simple things that we can all do when we meet them in our clinical practice. So I think
that's it. So before we sign off, and I'm thanking Helen very much for joining us today, for a very informative update and also information on those 3 topic areas. So before we sign you off and shut down, has anybody got anything they wanted to say or ask Helen? Right. Well, what we'll be doing is we've recorded this webinar, and therefore I will set it up for people to look at a later date. Kim will put it on the Moodle site. That will, it takes a little while for it all to save and go up, but I should have that up and ready for this afternoon for you to refer to, but also for the people that weren't able to join us. Thank you very much for your participation. Your questions are always stimulating, and I'm going to shut it down now.
Thank you. Goodbye.
Bye.